Video object
Nada. नवीन नरेश Chandu, can you hear me, Chandu? Am I audible, Chandu?
Very clear.
Okay, you are also very clear. So, अभी ठीक है?
Very good.
तो बोला ना?
Very good, boss.
So,
Really
only thing, my only disappointment for me is few people have mailed me saying that, sir, please don't use Zoom, you use some other thing. But as of now, at the last moment, we cannot change it. Even if we can change it, we cannot send it to all of them.
correct.
I am assuming that there may be little bit less participants.
Why?
Zoom है बोल के थोड़ा लोग
Because of China's issues.
हाँ actually Zoom उन्हें is a US Zoom उन्हें बंदा चाइना का है मगर उन्हें US से ऑपरेट कर रहा है is a US person US citizen है तो अपने इंडिया में जाके उधर वो करते हैं ना मगर still since he is a Chinese person they don't want to
Correct.
boycott. So
Now it is a
we talk with Dr. Kajal. Good afternoon, Dr. Kajal. I'm Dr. Rao from Hyderabad. Can you hear me?
అది మన ఇది లేదు నెట్ సరిగ్గా వస్తలేదు చూసిన నేను డిస్టర్బెన్సెస్ ఎందువలన విల్ సిట్ దేర్ ఓకే విల్ సిట్ దేర్
Can you hear me, Dr. Kajal? Dr. Kajal has sent 22 slides.
Oh,
But she said that she will complete it within her time. Dr.
Okay.
Kajal, can you hear me? Okay. Dr. Kajal,
Yes.
good afternoon.
Good afternoon.
Welcome to this webinar. I'm Dr. Raj Narsingh Rao. I'm from Hyderabad.
So nice to meet you.
The other doctor is Dr. Chandrasekhar. We both
good evening.
in this program.
Good evening.
This is Professor Chandrasekhar.
Good evening.
Yeah, nice to see you.
Same here. Where are you from, sir?
I'm a retired superintendent of the Gandhi Medical College. I'm a dean there, actually.
Great.
Yeah, man. I'm an honorary secretary for the International Trauma Care.
That's really good.
And my colleague, Dr. Raj Narsingh Rao, is a treasurer, basically, for the International Trauma Care. Indian
You
chapter.
all are anesthetists, sir?
Yeah,
We are all anesthetists. We both are.
You are anesthetists?
Yeah.
Both are anesthetists.
Is this society working?
It's working, but not that active. Actually, you know about this society. It was started long back in 1990, 89, 90 in Australia and US. But in the initial one decade, in 10 years, it was disseminated throughout the world. But somehow after 2000, nobody took much interest about this society. And the founder of the society, ITACCS, is Martin Isaac. We were associated with him, and he passed away in 2011 or some. He did a lot of work for this society. Our Tanmay Das also joining, the president of this society. I think So, what is your routine? You are a trauma anesthetist.
I'm trauma anesthetist, and I'm looking after the 250 bedded exclusive unit of trauma in my setup.
I'll introduce Dr. Tanmay Das. Dr. Tanmay Das, can you hear me?
Hello.
Can you hear me?
Yeah, I can hear you.
Good
Okay.
evening, Tanmay.
I can hear you.
Tanmay, good
Yeah,
evening.
good afternoon. Good evening. Good evening.
Dr. Chandrasekhar is there. Myself, Dr. Kajal has joined. Dr. Shekhar Reddy is joining from UK.
Yeah, can you hear me too?
Yeah, we can hear you.
Yeah.
Dr. Shekhar Reddy. Good morning. Good morning to you, Dr. Shekhar Reddy. I think it's early hours of Saturday morning for you. Am I correct? Dr. Shekhar.
Hello, sir. Good evening. This is Dr. Shekhar Reddy here.
Good evening,
Shekhar.
Sir, I just
How are
logged
you?
in a little bit early. Yeah, good, sir.
Yeah, you
Just-
did talk early. Just we are 10 minutes away to start the session.
That's okay. I just want to be careful because, sometimes these gadgets don't work in the.
Yeah.
You're right.
So,
Yes.
Dr. Shekhar, presently in UK, which hospital you are associated with?
Sir, I'm here in the NHS Highlands. That's in northernmost unit, almost the big hospital in the north of Scotland.
Okay. So just to mention I just want.
Yeah, that's okay, sir. Just a brief 2 lines should be sufficient, just people to know. Chandrasekhar, sir, how are you?
Fine, Shekhar.
Yes, sir.
When
Sir,
you gone there?
just a week ago I came here, sir. My daughter is here. She's in med school here.
Oh,
And she got stuck, and she's only 18 now, just gone past 17.
okay.
And she was feeling a bit lonely, and I thought, on balance, it's better that I come here rather than, if she comes there, and if the situation gets worse, and then if she cannot come back in time for the university.
Yeah, I know. But how the things are there?
Professor Dr. Ganapati, good afternoon.
Good evening.
Good evening, sir.
Good evening, Ganapati sir.
Good evening.
Sir.
So all the key members of ITACCS are there. I'm very happy to see Dr. Tanmay, Dr. Ganapati, Dr. Chandrasekhar, Dr. Shekhar Reddy, and Dr. Kajal. Everybody are there. I think Dr. Bala Venkat has to join us.
Dr. Raman Rao also should
Dr.
join.
Raman Rao also has to join us. We are so many of them may not be coming on this Zoom. We are telecasting on YouTube also, so many of them may be on the YouTube itself.
Okay, sir.
My friend Upender, I'm very happy Upender is joining. I was really, he's the man, key man for this IT. You are asking Dr. Kajal, Dr. Upender played a very key role in ITC to India. Oh. Ramana Rao is also joining.
That's good, sir.
Dr. Ramana, good afternoon.
Hi, Dr. Chandrasekhar, hello.
Can you hear us, Dr. Ramana?
Yes, Dr. Rajnath Singh Rao. Yes, thank you.
How are you, Ramana?
Sir, Ramana Rao, sir, Shekhar Reddy here.
Oh, nice meeting you, sir. Very good, right. Dr. Tanmay Das, good afternoon to you, and then nice seeing you. Dr. Ganapati.
Hello.
Dr. Kajal, hello.
Hello.
Nice of you to be there with us today. So, Dr. Rajnath Singh Rao, my sound is okay with you? Am I audible to you?
You are audible, but little bit low tone. Your tone is not that good. Dr. Upender,
Hi, Upender.
we are just remembering you because you are the key person who brought ITACCS, ITC to, especially to Hyderabad. So you are that's what we are thinking. Upendra should join so that he will be a part of this webinar. Thank you, Upendra, for joining us.
Okay, sir. Good evening. Good evening, everybody.
Good evening.
Dr.
Dr. Upendra is
Good
retired,
evening, sir.
was a professor in Gandhi Medical College. Now he heads the anesthesia department at Asian Institute of Gastroenterology. Dr. Debashish sir.
Hi everybody. Good evening.
Good evening.
Good evening.
Good evening to all of you.
Good evening.
So I think everybody, we can get introduce ourselves. Dr. Bala Venkat also joined. So most of the panelists who have joined here, who are there for today's.
Shall we give another couple of minutes so everybody will be there? So
Yeah, we'll start sharp at 5 o'clock. This is also going to YouTube. So we just start, the real program will start at 5 o'clock. This just was the introduction, what we wanted. So we opened it a little bit earlier. Good afternoon. Your voice is a little bit less. You can increase the volume. Dr. Bala.
Yes, sir. I'm going to switch over to another system now. So this is only temporary, sir.
Okay.
Bala, good afternoon.
Good afternoon, sir. How are you?
Bala, good evening.
Good evening, sir. Good
How are you,
evening.
Bala?
Oh, nice to see you, sir. How are you, sir? I'm doing good. I'm doing good. இதுல போட்டு பண்றோமா வைஃபைல 5 minutes இருக்கு அவன் வந்துட்டானே
Dr. Upendra sir, it's Shekhar Reddy here. How are you?
Good evening, sir. How are you? Fine.
I'm good. Good.
Hi Bala, hi Upender.
Good evening.
hello Ganapati sir. Hello, good evening. Nice to see you after a long time. Dr. Upendra Gaud, good evening.
Sir, good evening, sir.
So still we have not moved on to YouTube. So once it's sharp at 5, we want to play it on the YouTube also. So
I think we all have to mute our microphones. Otherwise, there will be a lot of clatter as the meeting starts. I think we may have to remind everyone to make sure that the microphones are muted. Otherwise, there will be a lot of background noise. So maybe whoever is speaking and that person will just switch on their microphone.
Sure. Sure.
Welcome, Dr. Debashish.
Bala, thank you so much. Great to see you. Great to see Dr. Ganapati, Tanmay. I haven't met the others, but welcome to all of you. I'm Debashish. If you don't know me, I'm a consultant at Apollo Kolkata. And it'll be brilliant to interact with all of you, hear all that you have to say. We are going through really tough times here in surgery, but we are coping. That's the most important thing.
And Dr. Tanmay sir, it's Shekhar Reddy here, and my friend, very good friend from Bangalore, he was mentioning about me, and Ravi Hebballi.
I know Ravi very well.
Yeah, he saw the the flyer and he was mentioning about you.
Dr. Kajal Jain, welcome.
Good evening, Bala.
Moderator.
Yeah, nice to see you, Kajal. Welcome.
Thank you. Thank you so much.
Dr. Tanmay, you are looking very different.
Can you mute your video or audios?
Yeah, please ask everyone to mute their audios.
I think whoever is hosting can mute everybody else. They will have a master control where they can mute everybody else and allow one person.
I've muted everybody, but still some people are able to.
I think those people who have joined new and they're still, you have to mute them again.
దీనికనే చేయవలసి వస్తుంది నువ్వు వాళ్ళు ఫస్ట్ స్పీకర్ మాట్లాడుతుంటే చేయొచ్చు.
Good evening, everyone. This is Dr. Anil Kumar Molkor.
Good evening, Anil.
How are you, sir?
How are you?
How are
How the COVID?
COVID బాగుంది సార్. మీరు ఎట్లా ఉన్నారు?
Doing well, Anil. After a long time meeting you.
మీరు ఎక్కడ ఉన్నారు ఇప్పుడు?
నేను I'm a director in Mamata Medical College,
Okay.
Bachpalli. New medical college they've opened.
Very good. నమస్కారం నరసింహరావు గారు.
Yeah, that's why I'll just start. నాకు పెట్టి లోపల కనబడుతున్నాను. Good afternoon, everybody. I thank one and all who are here there to participate in this webinar. Before Dr. Tanmay Das give his message, I just want to tell something about the ITACCS, International Trauma, Anesthesia and Critical Care Services, which is now called as ITC. This was started in 1990. It is a multidisciplinary professional body, but it has gone well for all this one decade up to 2000. But somehow after 2000, many of them, I still remember in 90s, we have participated in many of the conferences, not in India and different part of the country. But after 2000, this ITC has slowed down. But thanks to Dr. Martin Isaac and thanks to our friend Dr. Upendra Gaud, who is there now today with us, they again brought the ITC back into action. Though we are not regularly conducting some conferences or other things, but still on and off we are active in this ITC. So with this small introduction about the International Trauma and Anesthesia and Critical Care Services, I request our president of ITC, Dr. Tanmay Das. Apart from Dr. Tanmay Das, the secretary of ITC is Dr. Chandrasekhar, who will be a coordinator for this particular session. And I am the treasurer. I am Dr. Raj Narsingh Rao, the treasurer for this. And many people who are there here who are very actively involved. Dr. Ganapati is there. He conducts a lot of trainings name of CTLS throughout the country in this in India. Apart from that, I see many of the people are there who are very much interest in this international trauma care and different training programs. So over to Dr. Tanmay Das. I request you to give a brief message, introductory note before the start of this webinar. Sir.
Thank you, Dr. Raja, and thank you, Dr. Chandrasekhar. It has been a great initiative. On
your volume is low.
Volume is low. Can you hear me now?
Yes, better.
It is low.
Okay, then just hang on till I.
Yeah, you carry on, Dr. Tanmay.
Yeah, if it is low, then I'll connect to my Bluetooth set.
Yeah.
You're okay, Tanmay, right now?
Yeah.
Are you okay? Can you hear me?
Yeah,
now?
you're okay.
You're okay. Carry on.
One moment.
This session is will be relayed on YouTube also. Just to inform all the participants and all the people who are there, panelists, that this will be relayed on the YouTube also. Dr. Tanmay.
Is the volume better now?
Yeah. It's good.
Yeah, carry on.
Yeah. Once again, I welcome everybody to this unique webinar, which is trauma during the COVID times. And I would like to just throw a little light on the educational activities that we have been doing. We conduct a course which is known as CTLS, which is kind of equivalent of the ATLS course, known well all over the world. We have been continuing to do it. I think the last course was, and we have already become a part of the national conferences in India, where this particular course is conducted on. We also conducted in the last annual ANESTHESIA conference. Now, trauma being such an important part of healthcare, we have focused on it for quite a long time, and all the members with me who are here, Dr. Balavenkat, Dr. Devashisha, we are a part of a fantastic teaching program. Now, I'll be very brief. I would like to focus on today why we are discussing trauma during COVID, because this pandemic makes brings trauma care on a completely or a slightly different focus. Now, initially, what happened during the lockdown was number of accidents came down, right? Even All India Institute converted their trauma center into a center. But as soon as it so happened that accidents did not stop completely, which case after the lockdown has been lifted, the trauma cases have been coming, and how we are able to manage, and I think all the other members will be able to highlight on that. It makes trauma care a little more complicated. We have to be more careful, especially when we are dealing with aerosol generated bacteria. Dr. Devashisha will highlight what we have been doing in Kolkata, and I'm sure all the members will also relate their experiences accordingly. Dr. Matthew, welcome. I can see you there. And welcome everybody once again. Dr. Ganapati has great insights on trauma care and teaching. I think we'll all learn a lot today from this webinar. So please carry on.
Thank you, Dr. Tanmay. With this, thank you for the message what you have given. Now I pass on the mic to Dr. Chandrasekhar. Dr. Chandrasekhar, as he has told, he was and retired professor from Gandhi Medical College. He played a key role not only in the non-government section, but he also with the government. He was also CEO of the Arogya Shri. Now presently he is working as a medical director for Mamata Institute of Medical Sciences. With this brief introduction, I pass on to Dr. Chandrasekhar to start the session with our first panelist, Dr. Ramana Rao. Dr. Chandrasekhar.
Thank you, Dr. Raja. Basically, we know pretty well it is India. Able to hear me?
Yeah, we are hearing you. Carry on.
Yeah. Basically, India ranks in the first number of the road accident deaths across the almost 199 countries reported in the world road statistics. Sure, India accounts for almost 11% of accident-related deaths in the world. So it's a very huge number. So I'm sure it is in a EMRI is playing always in a key role. That is a 108 ambulances. Dr. Ramana Rao is from the beginning, from the inception onwards. Dr. Ramana Rao and the Raj Nursing Rao, they were key players in the EMRI. And right now it is in a Dr. Ramana Rao is working as a director EMLC, that is Emergency Medical Learning Center. For you, Dr. Ramana. Now, can you come out of the statistics of the road traffic accidents in India and globally? Along with that, do you suggest any changes on-site resuscitation methods in the pandemic situation? Both the questions kindly you take it.
So thank you so much, the ITC office bearers, and thank you co-panelists and the participants of today's webinar. It's an honor to be amongst all these stalwarts, and I just wanted to recollect the nostalgic memories of over 10 years getting associated with the CTLS and ITC. From the pre-hospital care or the EMS perspective, trauma is the second leading type of emergency we attend. I just wanted to take you to some of the most recent data available at the national level. The report is released by the Department of Road Transport and Highways of 2018, which documented that for every 1 minute there is a road traffic accident, and every 4 minutes there is a fatal road traffic accident. Globally, if we observe about 1.35 million deaths, India is noticing about 150,000 deaths out of the 500,000 road traffic accidents which are happening. So as what Professor Chandrasekhar has mentioned, we are maintaining that dubious distinction of being in the globally first in terms of road traffic accident. Can I have the next slide, please?
Hello.
So this is a broad number of accidents which the MARTH or the Ministry of Road Transport is. Can I have the next slide, please, Dr. Raja Nursing Rao?
Yeah, I'm just.
Okay, so what I wanted to focus is that the 2018 MARTH data also talks about the dominating role of road traffic accidents in the rural India, where 6 out of 10 accidents are happening in the rural India, and the people who are also injured are from rural background. While globally, 90% of the deaths are happening in the lower and middle income countries. In India, we are seeing it in the very socially productive age group. But when we compare the grievous injured and the minor injured, serious cases, we found a 3:7 ratio. And when we look into the Indian number of case fatalities or the deaths when compared to the other countries where the road accident numbers are reported very high, like USA and Japan, our accident severity index, number of deaths per accident are very high in India. This reminds the group today that trauma needs to be given a lot of focus, because India not only has more major deaths, but the extent severity is also very high. Dr. Raja, can I go to the next one, please? So rural India and accident severity index are the points which we need to take into consideration today as deliberations. Coming to the COVID pandemic, Government of India for the first time by mid-March, it has come out with a very detailed guidelines on various facets of COVID-19, including the transportation. The standard operations which were issued by Government of India has really helped this organization to work very closely with the various state governments and even at the district level with the surveillance officers. And we were able to really contribute something very significantly in COVID and other related things, including the trauma also. Can I have the next one, please? I just wanted to highlight, can you go to the next slide, Dr. Rajan? Right. The COVID-19 medical transportation. Previous slide, please. Right. So it talks about how we can use some new call taking process at our state level emergency response centers, how our staff should be protected by the personal protection equipment, and how we need to focus on the disinfection of the ambulances and the training. But the very important message I want to bring to your today's discussion is deaths are inevitable, particularly when we do either primary transportation or interfacility transfers. The guideline has mentioned that when we in the pre-hospital situation we are encouraged to conduct the CPR, but we have also initiated a new thing which was done there during the non-COVID period, that we are using a transparent plastic sheet, and when we are continuing with the CPR interventions as we were doing in the pre-COVID era. This is one point I wanted to highlight, but in addition, there were other things like, we need to take care of the pulse oximeter, oxygen in the pre-hospital situation, IV lines, so on and so forth. The point I want to tell you is that in COVID-19 situation, in trauma cases, our ambulances are continuing with the CPR process, but using a transparent sheet so that the aerosol mechanisms can be prevented to a larger extent for our workforce who are there in the patient compartment of the ambulance. Next one, please. Can I have the next slide, please? So we have significantly reduced our number of cases of trauma. Earlier, we were attending about 3,000 every day. And during the lockdown and the post-COVID, we are state-wise, the number of cases have significantly come down by 33% to 50%. And but we are continuing our services in terms of attending to the individual emergencies and multi-casualty incidences. Thanks to our collaboration with the Stanford, where Dr. Math is also there today, we have developed some very highly evidence-based protocols in terms of patient assessment, analysis, and then I'm showing you one of the protocols in terms of how we will be able to do the pre-hospital care trauma patient assessment and what are the common interventions we are doing at the basic life support level. Next one. Next one, Dr. Rajan Singh Rao. I just wanted to tell you that GVK EMRI as a pre-hospital care organization has been getting extensive support at the district and state level. Our workforce is protected. We are monitoring the everyday ambulance COVID-related transports. I'm very proud to tell the group today that from March 16th, we have started daily monitoring. At this point of time, we must have associated with more than 300,000 COVID-related transports. On an average, we are doing about 3,600 transports along with the pre-hospital care. Communities served. The Government of India, including the Air Force, they have showered petals on our ambulances, and we are considered as a part of the COVID warriors. I just wanted to leave three good things what we have learned in the COVID-19. One is that the healthcare system has now fully accepted pre-hospital care as a part of the chain of survival. It was there, but it has strengthened. The pre-hospital system and the pre-arrival information to the hospitals has tremendously strengthened in the COVID-19 situation. Hence, it will have a favorable prognosis or the outcomes. The third component is pre-hospital care and emergency care, as stated by the World Health Organization, the 70.
Dr. Ramana.
Am I audible to you?
Yeah,
Yes,
yeah.
please.
Can you tell the last slide again?
The last slide highlights the integration of the pre-hospital care services during the COVID epidemic, that we are now considered as a very strong member in the public health care system and the chain of survival. We are able to protect our own workforce, and we have contributed to more than 300,000 transfers and an average of 3,600 in all our operating states. Communities we serve, the government has also recognized us as member of the COVID warriors, and the photograph of the ambulance being showered with rose petals a few weeks back is something which I wanted to share with the group here. And I want to recollect what World Health Organization in its 72nd World Health Assembly meeting said, that 50% of the lives can be saved if we are able to have a system with pre-hospital care and emergency care, particularly in the injuries. And the pre-hospital care is now a part of the universal health care. And I'm sure that the COVID has also not only created some catastrophic experiences, but it has also given us some lessons so that we can migrate to the new norms. And I want to thank ITC for giving this opportunity, and my team and Dr. Raja for creating this platform. Over to Dr. Raja Narsingrao.
Dr. Ramna, one more small question for you. How do you decontaminate your ambulances, and how do you dispose your waste management areas? What are the various protocols you are following?
Correct. That's a very important question. In fact, in the guidelines, there was mention about both the things, right? The disinfection of the ambulance, we have had during the Ebola time, 1% sodium hypochlorite being used, and we were using it a manual method. Fortunately, in the COVID-19, we were getting some machines, and then we are using spray. It has reduced our turnover time. That's one point as far as the disinfection. So we are doing it mostly in the hospitals. We call it base hospital institutions. As far as the biomedical waste is concerned, the donning and the duffing, we have been adopting a very interesting, and earlier also we were doing it. Now we are disposing of along with the other materials in the yellow bags in the hospitals. Yesterday, the Central Pollution Control Board has come out with guidelines, because in 2 states we are also dealing with the community level lab testing also. So we are using the biomedical waste disposals as per the guidelines of Government of India, the Ministry of Health and Family Welfare, and recently obtained guidelines by the Central Pollution Control Board.
Thank you very much, Dr. Ramna. It's a very good insight. Now I'll hand over to the Dr. Raja.
Thank you, Dr. Ramana. Thank you, Dr. Chandrasekhar. Now, our next panelist will be Dr. Matthew Sterlo. Dr. Matthew Sterlo is the Associate Professor, Vice Chair of Strategy, Director, Stanford Emergency Medicine International, and he is in the Department of Emergency Medicine, Stanford University School of Medicine. As the Director of Emergency Medicine International, he developed many number of programs, not only in their own country, but he has also developed a lot of programs even in India, in other developing countries, like Nepal, Ethiopia, Cambodia, and many other countries.
Raja, we're not able to hear Raja. Hello?
I just now are you able to hear me?
Yeah.
Okay. So again, let me introduce Dr. Matthew Sterlo. He's Associated Professor, Vice Chair of Strategy, Director, Stanford of Emergency Medicine International, Department of Emergency Medicine, Stanford University School of Medicine. As the Director of Emergency Medicine International, he developed many number of programs, not only in US, but also in India and other developing countries. We are very fortunate to have him here very frequently. He visits very frequently to India, and he has developed many programs for the doctors at a low resource setting. Like one of the programs which we were very much impressed was hospital physician training program, which was very much adopted and was utilized by two of the countries. Apart from that, he also made us to do some international programs. He got associated with the American Academy of Family Physicians, and he has brought to India the ALS, so Advanced Life Support in Obstetric programs, and many other programs to India. Thank you, Dr. Matt, for your association with the GVK MRI and with the India.
Dr. Narsingrao.
I request you to talk about the flow of trauma patients when they come to your emergency department. We talked about the pre-hospital care level, but now we want at the emergency department when the patient comes to you, how you manage in this COVID era. Dr. Matt.
Dr. Narsingrao, can you ask everyone to mute their microphones, please?
Yeah, actually, I am also muting it, but still they are able to come out. And can you please all mute your...
Or as a host, you just mute everyone.
I am muting it, but still they are able to unmute themselves.
Thank you, Dr. Raja Narsingh Rao. I appreciate very much the introduction, the kind words, and I also want to thank Dr. Tanmoy, Dr. Chandrasekhar, and ITC for having me here today on this fantastic webinar on this very important topic. I also just want to greet my good friend, Dr. Rao, who we have been working together now for, I don't know, many years, much over a decade. Always good to see his face. So thank you everyone for this opportunity. And I think, Dr. Raja, if you are able, maybe you can share some slides.
Yeah, sure. I'll just
prepared. But I'll spend a little bit of time talking about not just but trauma in how we manage it at Stanford in the United States, but also just mainly the changes that we've had to make to our trauma protocols. You know, a full discussion of how we manage trauma in the United States takes a long time, but I think there's a few key things that we've changed. A lot of that focus is really around protecting our providers and our patients, because we can be a source of care for our patients. We can be a source of care for the community during this time, but we can also be a source of spreading infection. And if we don't care for ourselves, then we can end up in a situation where many healthcare workers are getting sick. And we have seen that, especially in New York, where the outbreak was so severe. We saw, you know, a pretty high percentage of healthcare workers contracting the virus, upwards of 20 or 30% in some places. And we saw pre-hospital and emergency care and trauma care providers contracting the virus as well, which then takes them out of commission, potentially puts their lives and their families' lives at risk. So it's really important that we make the system changes, even to our trauma patients, to make sure that we are caring for them as well.
Can you see this? I'm sharing the slides, Dr. Matt.
I cannot see the screen. Can others see the screen? I can share my slides if you'd like. I can do that as well.
Just a minute, right? Just a minute, right?
But as you're doing that, I can kind of keep getting started. As Dr. Raja said, my name is Matt Strelo, and I serve in multiple roles at Stanford, but I'm an emergency medicine physician by training, which is we have separate emergency medicine and trauma teams, and we work jointly as a single unit, two parts of a single unit during a trauma resuscitation. The trauma surgeons focus on the operative care of the patient and the care after the initial resuscitation in the critical care unit. And the emergency department physicians focus on that initial stabilization, resuscitation, and diagnosis. Let me just double check.
Can you see the slide now?
I think they're coming up just now, yes.
Yeah. Okay. Okay.
Except for, can you go to the first slide, please?
Yeah.
There
Can you
we
see the
go.
first slide?
We can, it looks perfect. Thank you, sir. So go ahead into the next slide, please. And Stanford, just a brief background about Stanford itself. This is a little bit of an idealized picture. I wish the hospital looked like this, but in an artist's mind, if it was a perfect place, it looked like this. But our current hospital, we have two adult hospitals that are attached together, a newer one and an older one. And those adult hospitals are level 1 trauma centers, which is the highest trauma designation in the United States, meaning that we care for all of the sickest patients, and even the patients that require any subspecialty or super specialty care will come to our facility. We are one of the few facilities with this designation in the largest state in the US, population-wise, California. Next slide, please. In addition to that, we have also a pediatric hospital attached to our facility that we serve as the emergency department for. So this also has a level 1 trauma designation, and that slide is good. So we have a level 1 trauma designation for pediatrics, so the highest pediatric trauma designation. So we care for both of those patients in our emergency department and then get them to the right hospital, or whether it's pediatric focused or adult focused. So it allows us to really consolidate our trauma resources. But it's important then that our providers are trained both in the pediatric trauma care and the adult trauma care. So this slide here shows I returned from India on March 10th, actually, from being in South India. And it was, at that time, there was about a little bit less than 1,000 cases of COVID in the United States. And we were just about to hit that ramp up period that you see on this graph. And it was within a week that we started to see cases at my local hospital. We already were putting in place protocols, but we were, I would say, only mildly prepared, and we had to get up to speed quickly. We had 2 healthcare workers in our emergency department get sick immediately at the start of this, right after I returned. One of them is intimately involved in our care programs and our partnership with India and GBK EMRI. And at that point, we were concerned that we were going to be in a pretty bad state for cases and for providers getting sick. Next slide, please. So next slide. So we've implemented a number of different things to change to our trauma. So this is a picture of our trauma team, or part of our trauma team, getting ready during COVID for a trauma patient. And I think Dr. Rao mentioned something that's really important. Trauma is a continuum of care, and that continuum of care starts from the first responder, the person that finds the patient and calls for help, all the way through to the critical care. And we need to communicate information. So this group, this team is prepared because we get a call and we monitor a phone every day, every hour of every day. And if that pre-hospital team has been activated and they are going to bring us a trauma patient, we are called to let us know that that trauma patient is coming, which allows us to do probably one of the most important things in trauma resuscitation, which is prepare. So our providers are prepared. They have the typical gowns on, they have a mask, they have a face shield. For any trauma resuscitation, they have to have at least a gown, a mask, a face shield, and most of the time we're requiring a hairnet as well. And our pre-hospital providers have also implemented this kind of extensive PPE, or personal protective equipment, during the COVID pandemic. And I think Dr. Rao showed that India is doing the same in GVK, EMRI, and other EMS services in India. But that is, put a lot of stress and strain on resources and personal protective equipment, which I'll talk a little bit about. But the EMS system activates us in advance of arrival, which is critically important. The trauma team comes down then, and then the trauma team and the emergency department team organize ourselves into who's doing what during the resuscitation. This slide shows that these are providers that are fully ready to be at the bedside of a patient. But unlike a lot of times before COVID, where these providers would be standing right next to the patient, they're actually standing back, trying to keep that 2-meter distance. And really only the personnel which are necessary at the bedside, which are absolutely necessary, are next to the patient. And then you can see on the right, on the screen there, there's a person standing outside of the room. And we have limited a lot more than we used to, the number of people that can come into the room. Whereas previously, in a major trauma resuscitation, we might even have 10, 12, 15 people in the room, from X-ray techs to nurses to physicians on the trauma team, or the emergency medicine physicians, respiratory therapists, those sort of folks. At this point, only essential personnel, people that have to be at the bedside, are at the bedside. Others are standing back, and then a lot of people are outside of the room, not getting PPE on. They're outside of the room, but being next to the PPE, personal protective equipment, and then coming into the room if needed. This does 2 things. It limits exposure to these providers, and it saves PPE. So in this slide, what you can see is that we're performing an airway procedure on this trauma patient, right? So we're doing airway management. And we have moved from having a positive pressure device to using an N95 as acceptable for doing aerosolization or procedures such as airway management, where there might be aerosolization of the virus. So in this picture, the person doing the intubation has an N95 mask on. They've got a gown, they've got eye goggles. You can see though that the person on the other side of that person that's intubating actually only has a surgical mask on, and that should not happen. Anybody within 2 meters of a procedure where we could aerosolize the virus, so an airway type procedure, should have an N95 mask on. And this person then is not needed. And then you can see the person holding the ambu bag, or the airway bag, has another way that we're using to protect personal protective equipment and keep our supplies of N95s up. So this provider, or respiratory therapist or nurse in this case, has an N95 mask over their face, and then over the top of that they have a surgical mask. Now that's after this whole event is over and they're doffing the PPE, they will take off the surgical mask but leave the N95 on, preserving that mask and allowing them to keep that mask to see other patients, because it's been covered by the surgical mask for any large droplets. So really we want to get N95s if you're within 2 meters of an aerosolizing procedure, and you might have a surgical mask over that so that you can keep that N95 as reusable. Next slide, please. If you're doing a procedure that's not an aerosolizing procedure in a trauma patient, we do not require an N95. And actually, this provider, who is the same as previously, does have that N95 on. So I think in that other slide, she probably had that N95 under the surgical mask as well. So she probably did have that correctly. Then, but in this case, you would only require a surgical mask if you're doing a central line or some other procedure that won't aerosolize the virus. And that saves us from using N95s when it's not deemed necessary. Next slide. So overall, we have a 3-tiered trauma system where, as far as the categorization of patients, we categorize patients into the maybe sick in the pre-hospital setting. We call them 95s. the mid-level sickness, the 97s, and then the sick patients who are worse, they're very sick, these trauma 99 patients, we call them. All of those patients, though, get categorized into two groups. They get categorized into, they might have COVID or they have COVID symptoms. We call them persons under investigation, or they have no signs of COVID. If the patient has no signs of COVID, so the EMS providers ask them, do you have a fever, cough, sore throat, shortness of breath, or flu-like illness? And if they answer no, we're in the EMS team, the pre-hospital team informs us, and we use standard protective equipment then with a surgical mask, goggles, and a gown. If the answer to that question by the EMS or the emergency department teams is yes, they do have symptoms that may be related to COVID, we then use the protocol where we have the N95s if we're close to the patient. In the case of a patient who's unconscious and not able to answer that question, we consider them automatically high risk or a person under investigation. So this is kind of the workflow that we've been using, and the effect of this workflow has been really exciting because even though we had these couple providers get sick very early on in the pandemic, since that time, we've actually had 0 emergency department nurses at Stanford contract COVID, which is quite an accomplishment. Out of our hundreds of nurses, 0 of them have come down and tested positive for COVID. And I think that's because of all the focus on appropriately using PPE. Next slide. Have I been muted the whole time?
No.
No, okay. Thank you very much. That is kind of how we've tackled the COVID pandemic in order to keep our providers and our patients safe.
Thank you, Dr. Matt, for the excellent presentation, what you have given. I was just wondering, you have given very good, you told very good about the N95, face mask, and the face shield and all. Even the gown also you have given importance, but does head shield or the head cap doesn't play much role in this?
We have we don't mandate that in general as much, but I think most of our providers are now using a head cap because if there's a feeling that you might be getting particles in your hair and then later touching your hair or doing something that's going to then spread the virus. So we are using a head shield the vast majority of time. Compliance in general is debated between our emergency department and trauma teams a little bit, but we run, our compliance with the appropriate PPE in trauma resuscitations runs pretty high overall, somewhere between 70 to 90% would be my guess. And then with decreasing the number of providers in the room, which is also very important, right? Only having the essential providers in the room, especially during those aerosolizing procedures. We've been very successful at keeping people out of the room so that not to expose them.
Thank you, Dr. Matt. Thank you very much for being here for this webinar. And you were about how you have to go. I think you have to go for your hospital. I think you got up very early in the morning at 4:30 to attend this session. Thank you very much, Dr. Matt.
Well worth it, and I really appreciate the opportunity to see you all.
Thank you very much, Matt.
Now I hand over to Dr. Chandrasekhar and start with the next panelist, Dr. Chandrasekhar.
Now to the Dr. Kajal Jain. She's from the Department of Anesthesia and Intensive Care. She's a course coordinator, trauma anesthesia and acute care from PGH Chandigarh. To Dr. Kajal, what are the various protocols you are following in your trauma care center?
Yes, very good evening to all of you. And I bring greetings from my institute, which runs a level 1 trauma center and which caters to the entire northern India. So may I have my slides, please? So as a trauma coordinator, I'm in charge of the trauma intensive care, and I also look after the dedicated 5 operation theaters which run round the clock. Next slide, please. This was inaugurated in February 2011, and as all trauma centers would have, we have 4 levels with a designated floor plan. Next slide, please. So we get the specialty consultants available within 30 minutes, and which includes all the major specialties. We are able to take care of the patient within 30 minutes. The next slide. Being the Northern Tertiary Care Center, we get a lot of patients from the neighboring states, and most of the trauma which we received during this COVID era ranged between 20 to 65 years, although we get a lot of pediatrics and elderly trauma as well. So next slide. Next slide. So during COVID era, we received most of the patients with open fractures, and a lot of them came to us with isolated head injuries. Next. So the last month's statistics showed that most of the victims who were brought to us from various centers were victims of road traffic accidents, followed by falls, and then followed by machine cut injuries, and then followed by assault. So as pandemic COVID-19, we as anesthesiologists and trauma intensivists, we changed some protocols. Like we changed some logistics in the triage area. I'll share the pictures with you. We made it mandatory for all patients to be COVID tested, and administrative rounds to decrease this interperson, communication and social distancing. We started WhatsApp calls and weekly rounds, rosters. And we also started doing protected intubations in the triage. We also set up one COVID-19 suspect operation theaters for those patients who required urgent surgeries but did not have their tests. We also pepped up our protective personal equipments, which includes the shades and the goggles and the protocols for tracheostomy, CPRs, using mock drills and handouts. So cleaning and biomedical waste management was also handled accordingly. Next slide. So at the entrance of the trauma center, we have a guard who ensures that anybody who comes into the trauma center is adequately sanitized and is given a face mask, and then he is allowed to go inside. His temperature is also checked at that point of time. Next slide. So this is the screening questionnaire, which is a mandated thing, mandated piece of paper, as opposed to the only in OPD card. Can you show the other card? Yeah. So now we have 2 cards. This card, the card on my right hand side, shows the screening questionnaire. So all patients have to be stamped with these questionnaires before they come to trauma center, trauma triage. Next slide. Next. So as I said, COVID testing is mandatory for all patients coming to trauma center. Next slide. So this area, this is a bit crowded slide, but the one which is on the top shows the pre-COVID era where we did not have any partitions in our triage area. But later on, to ensure some distancing, since we do not have one dedicated room, we made cubicles. And in these cubicles, we tried to separate out the patients and decrease the crowd. Next slide. These are the administrative rounds with our director, and I'm also there in the picture. And we do WhatsApp calling for the trauma ICU calls. We do not go and visit till we get the calls. And once we get the calls, we adequately prepare ourselves with our shields and face mask, and then we go down. And we also have decreased our, exposure to this trauma center by making weekly rosters and giving a shorter duration of duties to our residents as well as to our staff. Next slide. So in the operation theater also, we have 5 operation theaters, but we have limited staff now as the number of surgeries has gone down by half. In the beginning only, somebody highlighted the statistics of India, and it sure has gone down by half. So in the month of April, we saw the theater was relatively free. So we limited our staff accordingly. And for the aerosol generating procedures, the protocols were in place. The residents wore impervious gowns, they wore a face shield, and they wore a FFP1 face mask. They were not given N95 because all these patients are COVID tested. They used video laryngoscope and they minimized the role of the use of positive pressure ventilation. This is a COVID suspect OT which has been created in the triage area. This is for those patients who have not yet been tested but require urgent surgery, especially extradural hematomas. And this is a fully functional theater. The patient stays in the adjoining high dependency unit till the reports are out. And if the patient is COVID positive, he's shifted to the COVID hospital, which is another building in the same campus. If the patient is COVID negative, then the patient is sent back to the ward. So we are using this COVID suspect OT for those patients for whom the testing is yet awaited. Next slide. Next slide, please. This is the trauma intensive care, which is a running facility with 12 beds. And we are receiving patients from triage when mostly this time during the COVID times, we receive patients with head injuries. Most of the patients were intubated in the trauma triage. Can I see the next slide, please? So, sorry, these are some of the procedures which are being done in trauma intensive care. So you can see they are wearing impervious gowns because all the patients are tested negative. Still, we do take precautions. So the slide on the extreme left of my side shows the residents doing suction of a critically ill trauma victim. So they are properly hooded, they are wearing their goggles, they are wearing FFP1, and then they are wearing impervious gowns. The second, the middle slide shows one aerosol generating procedure. This patient had to undergo upper GI endoscopy. And these are the gastroenterologists who came to do a bedside endoscopy. So they are in coveralls. So these are coveralls, they are not PPE 3. And the third one is one recovering patient of rib fractures who's tested negative and doing spirometry. Next slide, please. Can I see the next? So these are as I've already spoken, these are some changes which we brought about in ICU, the availability of face shields and FFP1 masks as per hospital protocol, and then ensuring cleaning with hypochlorite solutions, and then staggering of staff whenever possible. Next slide. So these are our warriors who go from trauma intensive care for intubations which have been attempted before and are difficult intubations. So they prepare themselves. There's a donning area outside ICU where they don this coverall. They wear a face shield, goggles, and N95 mask and a surgical mask over it. And next slide, please. Can I see the next slide, please?
Yeah.
This is the triage area where my two students, my two residents, are taking the history from the staff in the triage area before intubating. They are provided with a video laryngoscope and all the necessary equipment like HEPA filters and a Yonker suction, and there is a Nambu bag with the closed suction system also available. Next slide, please. So as everybody else is doing, we are doing protected intubation and ensuring all the steps which have been highlighted by the various guidelines. Next slide. There's a donning area where the resident dons and then comes back to the intensive care. All the aerosol generating procedure and its equipment are disposed of in the biomedical waste basket. It is properly discarded as per hospital policy. We do a weekly audit of all the intubations and all the patients who report to trauma center under our care, and we give the feedbacks and tweak our management accordingly. Thank you very much. Is there any question which I can answer?
You're able to
Chandrasekhar,
hear me now?
yeah, I can hear you now.
Thank you, Dr. Kajal, madam. Now, for example, if it is any emergency surgery, if you're offering to the patient, what are the various tests you're doing?
You're asking me?
Yeah.
Yeah, we are doing the COVID testing. We are doing the gene expert for those who require surgery within 2 hours. For those who cannot wait for the test are taken without the test in the COVID suspects. Otherwise, it is RT-PCR for COVID.
Okay. RT-PCR, how long it will take for you to get?
It takes about 6 to 8 hours. So for those patients for whom surgery is deemed urgent, we do gene expert, which is available within 45 minutes to 2 hours.
Okay. Thank you very much. Are you taking an CT chest actually? HRCT for all cases? Which takes
HRCT
about
test,
5 minutes.
If the patient requires, yes. If the patient is showing SARI or the patient is having rib fractures or is showing hypoxia out of tune, yes, we are doing CT, but not for all patients. CT chest is not done for all patients.
Thank you, madam. Thank you very much. Now I'll hand over to the Dr. Raja.
Thank you, Dr. Chandrasekhar. Thank you, Dr. Kajal. Now I'll go on to the next panelist, Dr. Bala Venkata Subramaniam. We always call him Dr. Bala with a short name. He's a senior consultant and academic director of Ganga Hospital, head department of anesthesiologist at Ganga Hospital and Medical Center at Coimbatore. He has organized many conferences at all levels. He's a good academician, a good speaker, a good clinician, and also a good anesthesiologist. So we have the honor of having him in this webinar as one of the panelists. Dr. Bala, to start with, I want to ask you, the first question is, the anesthesia of choice in a trauma patient during this pandemic, what do you choose?
Good evening to everyone, and it's a pleasure to be a part of this by International Trauma Care, and thanks to Dr. Raja Narsingh Rao for doing all this paid work to make this a possibility. I bring to you greetings from Ganga Medical Center and Hospital. It's a 500-bedded tertiary care referral center for trauma, orthopedics, and major spine surgery. And I would wanted to share with you, even during the lockdown in April, we are close to 600 surgeries being operated. And now in the month of May, we have crossed about 1,000 surgeries in our hospital. And as we are challenged, I think we need to innovate so that the patients do not suffer. So I think the priority has gone too much to the COVID patients, and the non-COVID patients needing surgery are truly, it's very unfortunate that many centers do not treat them. So this has been one of our main concerns, and we address this issue. Now for the question on what is the best form of anesthesia, it's spoken very well by both Dr. Kajal and Dr. Matthew that we need to be very careful with aerosol generation. So if you decide to avoid aerosol generation, I think your surgeries are much more safer. Fortunately, since we do a lot of ultrasound guided regional anesthesia, we do all the cases as much as possible under regional anesthetic procedures without conscious sedation. So the protocol is all the patients who are coming in with trauma, immediately we send them to the triage area to see for symptoms, and also we take a sample and send for PCR. We also get the PCR report with 6 to 8 hours. So we have two categories of patients. Patients who cannot wait for 6 hours. They are taken with all protocols in place, including the PPEs. But those who can wait, all the trauma victims are admitted into one designated floor, the first floor. And until the report comes, they are not moved out of that place, including for investigations, if they are stable, because they may contaminate the entire hospital, because it's a non-COVID hospital and there are several patients there. So even X-rays that are needed, CT that is needed for orthopedic procedure are done only after we get the PCR test as negative. So they are attended to, all their cares are taken care of, including pain relief, but definitive diagnostic procedures, if it can wait, we wait. But if it's an emergency, as I said, we go ahead and do everything with adequate precautions. I'm happy to share that until today, of all these cases, which we have done close to 1,800 cases, all them, I'm very happy to say that all have been COVID negative. So this thing very good clearly indicates the prevalence in our city until this point of time has been less. And when we wanted to go for general anesthesia, as it was mentioned, whenever you need to take when on patients with major polytrauma, one of the things which we have done is the intubation box. Several intubation boxes are available, but the one which we developed also gives an opportunity to use all the protocols that are needed in a difficult intubation, including a bougie. I'll have just a short video of the box that we have developed, which is connected to a negative suction. So can I have my screen sharing?
You want to have screen sharing, or shall we play the video here?
Sir, shall I play the video from here?
Oh, just the screen share. Dr. Bala, I think at this point of time, I will not be, I'm not able to share this.
Okay, sir, no problem. Yeah, no problem. So basically the box that we have evolved and developed is one which allows you to do even difficult intubations, which you have in trauma scenario. So it's a box which has got a width of about 30 centimeters and then a height of about 60 centimeters. So bougies can be used freely, and this box is connected to a negative, it's a negative pressure chamber because it's connected to a suction. And you leave the box in situ for 15 minutes after intubation, so that all the aerosols that are generated are sucked out. And subsequently, we go ahead and do the surgical procedure. In a nutshell, if you want to speak about anesthesia, preferred anesthesia is regional. And when we do regional technique like spinals, epidurals, nerve blocks, we made it a point that new normal is we don't sedate the patient, because if you sedate the patient, then you may have to use oral airways, and if they start snoring, and if they become hypoxic, then you need to manipulate the airway. So we made it a policy that we don't give any sedation of any form to all the regional anesthetic procedures, even though the PCR has been negative. So this has been the new normal for our regional anesthesia. And when we give general, we take all protocols to make sure that the healthcare workers do not get infected.
Dr. Bala, just one thing for my own interest, I'm asking this question. Regional anesthesia is best, but suppose somebody is giving regional anesthesia and operating from the head end of the patient, is it still recommended? For example, where the hospital I work in, Ophthalmic Institute, they give a block. His airway is almost, even though you cover his airway, but still he will be in his, we sedate the patient, he's in a semi-conscious position, he will be breathing in and out. So you still think that is a better anesthesia for that patients, that type of patients where they are operated from the head end?
No, operation from head end definitely poses a huge challenge because you can't avoid aerosols. And fortunately, in our hospital, except facial-maxillary surgery and trauma, where we go for general anesthesia, the peripheral limb surgeries all can be done with the blocks without sedation. But what you speak about, the ENT surgery and ophthalmic surgery, they're completely a different set of surgeries where we need more protection for the doctors.
Thank you, Dr. Bala. Dr. Bala, can I ask you one more question? Because the previous speakers, it has been not covered. Is blood transfusion safe in trauma patients from donors from the community?
Oh, so this is a very, very good question, sir, because many people are concerned. Like now we get blood donors in major trauma, you need to transfuse blood. And the common concern is we get it from the community. So what are the chances of contracting a COVID-19 from a blood transfusion that has been administered from the community, or all the blood donors tested for COVID before they donate blood. So the answer to this is a very big question, and the answer to this is it has been found out that the viral load in the blood is, even in a COVID-19 patient, is only 1%, and it does not have the propensity to induce an infection. So the correct protocol is, do the blood donors undergo COVID test before giving the blood? Answer is no. The answer is, are the patients more prone to develop an infection because of this transfusion? Answer is no, because it's only 1% and the viral load is only 1% in the blood, and it does not transmit an infection because of the blood transfusion. So that's the current thinking and the guidelines.
Dr. Bala, before I go to the next panelist, can you just brief your guidelines and principles for managing a polytrauma patient who is tested positive for COVID-19? Can you brief it?
Yeah, I think the most important things is it's an emergency, a COVID-19 coming in for a polytrauma. I think things have to be initiated, including massive transfusion protocol, immediate intubation, resuscitation. So the number of people, this has to be done by the most experienced anesthesiologist. So this will allow that he will perform multitasking and will keep the number of healthcare personnel inside the operating room to very minimal, number one. Number two, when the aerosol generating procedures, the complete PPE kit is worn, and all those who are inside will be on a complete PPE. And we will operate in an operating room which has got because we don't have a negative pressure operating data. So we use what we have done is the airflow exchanges per hour has been increased to 22. Normally it is 6 to 8 cycles. So we have increased to 22 cycles, and this helps to decrease the viral load. And we make sure that immediately after the intubation, the HMEF filter is put to the machine end of the endotracheal tube, and one more HMEF filter in the expiratory limb, so that this prevents the virus from contaminating the anesthesia machine. All the rest of it will be done with complete PPE with minimum number of healthcare workers inside. And one of the important points to notice, the blood is not very infective, contrary to the initial belief that when you operate on a blood, when you use a drill, whether the splash that is coming out can cause infection. So most of the current studies indicate that blood does not have very high, and getting infected is very less because of the drills that they use to.
Thank you, Dr. Bala. I have seen your aerosol box. It's very good. It is a very superior model over the other aerosol box which are there in different hospitals. I think it's the same one which have the hands also. But does it any difficulty if you cover your hands with that?
No, sir. No, actually not really. In fact, it gives you plenty of space to work. In fact, 4 hands can go inside, 2 for the physiologist and 2 for the assistant. So it's quite large enough, and we worked on it with several dimensions, and eventually we frozen this, because even through your hand goes visible space, so that you are not restricted and the elbow moves very freely inside while intubating. Probably I can share it to your email, and at the end of the webinar you can put the video if possible.
Thank you, Dr. Bala. One more last question I want to ask. Yesterday we were, I think you might be also be there in the Royal College of Anesthesiologists, where one of the panelists was telling that to create a negative pressure in the aerosol box. Can you just tell me how to create a negative pressure in the aerosol box? He's not talking about the negative pressure in the, he's talking about the negative pressure in the aerosol box.
So the simple thing is, the aerosol box which we have, which we are using, there is a suction port. The central suction is attached to the suction port. This is just to suck out all the aerosols that are getting generated. You leave for 15 minutes after the procedure is over. Both during intubation and after intubation, you leave the box over the patient for 15 minutes and the central suction is connected to it. So the concept is it sucks out all the aerosols that are created and you're creating a negative pressure inside the intubating box.
Thank you, Dr. Bala. Thank you for all your inputs, what you have given regarding the aerosol box, the theater, and especially the blood transfusion and all. Thank you very much. Now, for all the people who are
Thank you, sir.
All the people who are there, I just request our center, GVK MRI, to have a small mock drill, how they have to manage a patient when a polytrauma patient comes to the emergency room. I just wanted to have them play there. They are there in the simulation complex of GVK MRI. GVK MRI has a very good simulation complex where we conduct many number of programs. So this is just 4 minute video. So 4 minutes play it will be. So please watch 4 to or it may take maximum.
Trauma case scenario. 35-year-old male Mr. Srihari with history of polytrauma brought to the emergency department who was hit by a speeding car while crossing the road. After taking all standard precautions, the casual team lead checking for any major bleed. He noticed there is a major bleed externally the left lower limb. Asked Mr. Naidu to apply a tourniquet. Checks the C-collar. C-collar is secured. Severe pain. Asking for pain medication. Airway is patent and protected as of now.
Namaste.
Asked Ravi to put 10 liters of oxygen via non-rebreathable mask. Assessing breathing, expose the patient's chest, ask to connect the monitor and secure IV lines and drop blood for investigations. Notices tracheal deviation to right, jugular vein is distended, has no swelling hematoma of the neck. Notices bruise over the left side of the chest, asymmetric chest rise on the left, it's tender. On auscultation, finds decreased air entry on the left side. On percussion, there is a deeper result.
Okay.
On the left side. He checks the vitals, heart rate is 110, respiratory rate 30, saturation 90% on 10 liters of oxygen, BP 110/70. Ask Ravi to increase the oxygen to 15 liters. Advise Naidu to give injection morphine for pain. Diagnosis of tension pneumothorax is made. Plan for an urgent needle decompression in the 5th intercostal space is in between anterior and mid-axillary line. Patient feels better, able to breathe now. Airway is patent and protected. Breathing symmetrical chest rise, bilateral air entry present. Plan for chest drain insertion in the same location. Checking the circulation, peripheries are cold and clammy, pulses are feeble, CRT 5 seconds. Monitor now showing heart rate of 122 per minute, blood pressure 90/60, respiratory rate 20, temperature 98.4. Suspecting shock, advise Naidu to give 1 liter bolus of normal saline, tranexamic acid 1 gram and ask for O negative blood. Looking for the source of bleeding, blood on the floor and 4 more on his mind. Examining the abdomen and pelvis, there is no bruise, swelling, distension, bowel sounds present, no tenderness or girding. Tenderness over the pelvis is noted, there is capitis present, pelvic binder is being applied. Calls for portable chest x-ray, pelvic x-ray, XSC spine, wants to do a fast scan. Examine the lower limbs, left lower limb, is a deformity, feeble pulse is present, left tibia fibula fracture, splint being applied. Ravi notices the patient is becoming drowsy, unresponsive, saturation dropping 84%.
Are you okay? Are you okay?
Checking for response, no response, pulse present, not breathing, heart rate 70 per minute, respiratory rate 8, not adequate chest rise. BP drops to 60-40. Using aerosol box, opens the airway, covers the face with a transparent sheet. They start back wall mask ventilation with HEPA filter attached. Planning for intubation to secure the airway. Tube is being placed, connect to the ETCO2 and connecting the ventilator with HEPA filter. Massive transfusion protocol ordered. Reassessing the ABC, airway secured, breathing adequately oxygenated and ventilated with respiratory rate of 20, tidal volume of 600, P of 3, FiO to 100%. Circulation, blood transfusion is ongoing, vitals now, pulse 100, respiratory rate 20, BP 170, saturation 100%. Moving for the disability.
Thank you all, Dr. Ravi, Dr. Keshav, Dr. Ravi, for conducting this mock drill. Just for a change, to have a break, I wanted to conduct this mock drill, which regularly we have programs like ATLS, ITLS, CTLS. My friend Dr. Ganapati is there who conduct a lot of CTLS programs. So just for a change, I wanted to have this mock drill. Thank you all from the simulation complex of GVKMRI who has taken a lot, put a lot of efforts to participate in this mock drill. Next we'll go to the next panelist. The next panelist is Dr. Debashish. Dr. Debashish is from Calcutta. He is a senior consultant surgeon at Apollo Hospitals, Calcutta. He has a special interest in trauma management. He is a ATLS certified. He's a national instructor in India for the comprehensive trauma life support, and I had the opportunity to be one of the instructor along with him in many of the programs which we conducted in Ganga hospitals. I'm very fortunate that Dr. Debashish accepted our invitation, and he's here today to be one of the participants. Dr. Debashish.
Good evening to all of you, and thank you, Dr. Raja, for those very kind words. First of all, before I say anything, can I congratulate all of you who are here, all of you who have showed your videos, and I think you're doing superb work, and all I can say is God bless and congratulations to all of you. It also makes me humble that me and Tanmoy represent Apollo Hospital as part of the entire northeast of India. And thank you again for letting us come on to this webinar. Can I have my first slide, please?
Yeah. Dr. Debashish, can you tell about the trauma load during this pandemic period, how you are managing the in your hospital? Can you just brief about that?
Sure. I think this slide that I prepared is useful. I think overall, the simple answer is yes, the trauma load has decreased. But if you read below, the actual decrease is only about 14% compared to the workload of Apollo Hospital in any 8-week period prior to the pandemic that we are witnessing now. And I think the decrease is primarily because of the reduction of the high-speed motor vehicle crashes. that are pretty common in Indian roads, as we saw in the first discussion. But equally, there are certain traumas which have offset that decrease. And as you can see in this slide, the number of plastic surgery cases are about half the number of orthopedic cases that we have seen in this 8-week period. And this is essentially because we are seeing quite a few of finger injuries. You know, people are doing now that they're at home, they're doing a lot of DIY stuff. They're doing, a lot of people are trying their hands in cooking. And as part of this, we are seeing a lot of finger injuries at the moment. Secondly, a number of burns cases are on the increase because, again, people doing domestic chores when they are not especially good at it. The increase in the maxillofacial percentage is essentially, I think, a reflection of domestic violence, which is, again, well-known published figures now following people being confined at home and having mental issues. However, the load in our hospital, although it is less, but certainly very significant even now, and we are trying to do our best to cope with it. Can we go back to the next slide, please? Okay. Now, as far as the approach to a trauma patient in our hospital, besides the usual methods that we all know, the primary survey and the secondary survey, I think the main focus, the main new focus is whether a trauma patient requires immediate surgery or not. And by immediate surgery in our hospital, we take it as between 6 to 24 hours. And the reason is very simple. In our hospital, at the moment, we are doing HRCT chest and RT-PCR. We are not doing gene expert. And RT-PCR takes approximately 12 hours in our hospital. At the least, we will get it in 8 hours. And therefore, we are coping by deciding whether the patient needs immediate surgery or not, which is within the next 6 to 24 hours. If the answer is yes, then we have a dedicated COVID OT for these patients. We have a green corridor, and I'll explain what is green corridor. And obviously, the full PP is being used. If the patient does not require immediate surgery, then we are doing HRCT chest for every patient. And once the HRCT chest is being done, these patients are being shifted to a dedicated COVID suspect ward. Next morning, we are doing RT-PCRs on all these patients, and the reports are coming back in the evening. If the report is negative, we are then shifting the patients back to the normal ward and treating them as per merit. But if the RT-PCR is coming back as positive, then they are being shifted to the dedicated COVID positive ward, and operations are being done in the dedicated COVID positive OT using, again, the green corridor facilities and the full PP. Next slide, please. Now, what are the facilities we have developed in our hospital for COVID patients? I think the concept of the green corridor. The green corridor essentially means that besides isolated ward for the COVID patients, we have COVID ambulances, we have COVID lifts, and we also inform the security people in advance who clear the entire passage of a COVID patient's transfer between departments. And if the COVID, so for example, if the COVID patient goes from the emergency to the OR, from the OR to the ward or to the radiology. So this is the concept of green corridor. We have a separate isolated RT-PCR testing ward with fully protected doctors who are doing the testing. We have a dedicated COVID OT complex, which has its own entrance and exit, which is utilizing the facilities of being totally isolated from the rest of the OT complex. It's a negative pressure OT unit. We are also having the anesthetist using the shield, as we saw in Dr. Balavenkat's slide, although it is not of that high level. May I mention here that we are doing laparoscopic surgeries. It's not that we are doing everything open. What we are specifically doing for laparoscopic surgeries is something that I would like to share with you. We are using a very indigenous method in that we are having a chest drain bag which is being primed with hypochlorite solution, and to the exhaust of the chest drain bag we are fitting in the nozzle of a suction pipe which is then connected to the main suction apparatus with a filter inbuilt in between. This is a completely separate suction device, different from any other suction device that can be used during the operation. And this is essentially to suck out the aerosols that are being generated inside the abdomen and minimizing the leak from the port sites. So this is what we are doing for laparoscopic surgery. I mentioned about the dedicated COVID OT complex. Besides this, we have a dedicated COVID suspect ward, which has its own intensive care facilities, besides a COVID positive ward with its own intensive care and high care facilities. So these are the facilities we have developed over the last 2 months in our hospital to treat COVID patients. The other problem surgically that we are facing is that what happens to the patient after the operation. The patients who are COVID positive, they go straight back to the COVID positive ward. Those who are COVID still suspect, because we have not had time to investigate them, they go back to the COVID suspect ward, and those who then turn out to be negative are transferred back to the main ward. But the problem we are facing is, how do we look after these patients post-operatively? When they go to the COVID ward, we have a dedicated COVID consultant team who do a 1 in 6 rota, and they go and see every patient twice a day, besides the normal doctors who are in the COVID ward. But what happens to the primary team that operates on the patient? Because a surgical trauma patient requires a lot of monitoring that a physician who is the COVID consultant may not be able to. And therefore, what we have done is we have developed a 1:5 primary MD, which is the surgical team rota, which comprises the consultant, the junior consultant, the senior registrar, the RMO at all levels, the DNB students, and we made a 1:5 rota in which one member of the team goes in daily to the COVID ward. This is besides the COVID team to see the patient. We have a dedicated mobile phone in the COVID ward with its own WhatsApp communication. So therefore, the team member who is in the COVID ward actually can communicate with the rest of the team outside the COVID ward, can send videos, can send photographs, can have a video call, can have normal telephone calls to discuss anything about the management of the patient. Any radiological investigations that might be necessary, such as X-rays, are being done with technicians going into the COVID ward with a full protection. However, the problem arises is if they have to come out for a CT scan or an MRI. Now, we have a dedicated CT scanner in our hospital for COVID patients, where the HRCT tests are being done, and we use that for any post-operative X-rays that are necessary, CT scans that are necessary for COVID patients. The problem comes with the MRI, because we do not have a dedicated COVID MRI. So it is rare, but it has happened. Even last week, there was a patient who required an MRI, and we had to obviously isolate our MRI and post the procedure. Once the patient had returned, we had to sanitize that MRI, put it out of function for a few hours, and then reuse it for normal patients. So that is the problem with any patients requiring radiology. The other problem is, when do you discharge trauma patients from the COVID ward? Now, This requires a lot of liaison between the primary MD and the COVID consultant. The COVID consultant decides when the patient can go home from his COVID symptoms. Now, if once that is achieved, the problem is, does the patient require any further dressing post-operatively? Does the patient require any further stitch removals, feeding jejunostomy tube removals? These sort of problems come into the picture. And unfortunately, at the moment, if we discharge patients home, there is no facility for somebody to go to their home and continue with the dressing. So therefore, we are having to keep those patients in who are requiring dressing in the hospital, even though they can be discharged from the COVID symptoms point of view. The final problem that we are facing is regarding the follow-up. So we have taken discussion amongst ourselves that post-discharge, we are keeping the patients in their home for 7 days quarantine. There are a lot of patients, and this is a practical problem, they say we are not able to quarantine at home. So what we are doing for them is the hospital has tied up with a local hotel, and we are transferring these asymptomatic patients post-discharge to a hotel. If necessary, we are having doctors or junior staff to go there once a day at least to look after them, make sure they're okay. And we are doing this for 7 days. So our quarantine period post-discharge is 7 days. And therefore, any further treatment, follow-up, stitch removal that has to be done, we are scheduling beyond 7 days after discharge. So this is in a nutshell our personal way of dealing with COVID patients as of now.
Thank you, Dr. Debashis, for your lucid presentation and giving all your experiences, what you're doing in your hospital. I then switch on to the next speaker, next panelist, Dr. Anil Mulpuri. Dr. Anil is a medical director and cardiothoracic surgeon at Sunshine Hospital. He's a reputed thoracic surgeon and great teacher. He is a qualified ATLS instructor and helps us a lot in conducting a lot of trauma-related training programs with our GVK MRI. Dr. Anil.
Yes, sir.
I just want to ask you, as you are the medical director and the CT surgeon, what are the problems you are facing in organizing trauma services at your hospital in this COVID era?
Yeah. See, the first and foremost problem which I face is the triage. Now, you have a patient who walks in with trauma and you do not know whether this is a patient who has got coronavirus or his attenders who are walking in. So that is the first problem. Now, the second problem is the zoning of the emergency room is difficult. Now, if you see the way PGI has organized, Dr. Kajal, I really congratulate the way they are able to get the test within 45 minutes. Whereas here, even today, it is unfortunate. I'll tell you why in government of Telangana, with the rules and regulations, we are unable to test so rapidly. And therefore, it means that even though we know what is the science, we are unable to actually test these patients. The third important problem, which I regularly have, is what about the diagnostic radiology in these patients? When they go for an X-ray, where there may not be a gross contamination, but if they go for a CT scan or an MRI, what are we going to do? So there is a lot of housekeeping issues. We'll have to make sure that the radiologists, radiology technicians, they all have personal protection equipment. And after that, cleaning the machine between the tests has been a nightmare. Now, the next thing is about the operation theaters. Now, not every hospital can quickly adapt to the problem and have a separate corridor for the patients who are suspected of COVID. Now, as I said, in trauma, I don't mind waiting for a day for, say, orthopedic trauma. But then if the patient has to go to a theater, I have no mechanism apart from HRCT to see whether this patient is having a possibility of coronavirus. And let us say if he has, Then I have dedicated one operation theater with the intubation box, as we have discussed with the other panelists. And the next is, once you move these patients into ICU, again I go back, HRCT, because you're going to have up to 1 day. Though you contact the lab, you talk to microbiologists, they say, 6 hours is their run time. But then the government facilities are overwhelmed. And even as I speak to you today, the freedom of having to send the samples to a private lab, that luxury we do not have in Telangana. This is unfortunate, and that means that we'll have to work around these government regulations, and we are unable to do what people in other parts of the world or other parts of India are able to. Now, when it comes to the question of the managing the staff, what we have done is we have divided into 3. So when the actual lockdown was happening, I have asked only 30% of the staff members to come to hospital. The others I have kept as reserve. So that meant that I will not have a nightmare of no staff, because most of them are either afraid or they have tested positive. So I think these are the administrative issues, apart from the surgical issues which I face when I have the COVID era.
Thank you, Dr. Anil. With this, I move on to hand over to Dr. Chandrasekhar to take the next panelist, Ganapati. I request all the panelists to be there because there are a lot of questions that are popping up on the screen. And I think at the end of the session, they have to answer all these questions. Dr. Chandrasekhar, can you?
Yeah. Thank you, Raja. Now, my good old friend, Professor Ganapati, is a critical care physician, national director, CTLS, and he's an international course director. He's an international trauma care chairman, and he has got a Dhanvantri Institute of Medical Education and Research. He's a specialist in clinical and toxicology and a snake envenomation. And he is trained in a lot of new things. He's training in new protocols, and he's a very good critical care physician. Now I'll ask Dr. Ganapati, are you taking as a director for the CTLS, any modifications in the protocols during this COVID period, Dr. Ganapati?
Yeah. Good evening to everyone. So almost all the speakers have spoken about this, but there should be some modification, because what strategies we adopt at various level of managing trauma patients. So we divide into 3 points of care. One in the trauma bay, that is in the emergency room. The next in the operation room, and in the intensive care. In the trauma emergency room, though they have told, I just want to repeat it, trauma patient evaluation should not be delayed to determine COVID-19 status, but appropriate precautions should be taken. Because here I want to insist both on corporate hospital and in a normal government hospital. So the patient should be treated and proper precautions has to be taken. And we have to ensure strict PPE for droplet contact precautions for all patients, which is normally done. If a patient has got upper respiratory tract infection, immediately place face mask on the patient. And as already the doctor from PGM told, we should ask history of fever, upper respiratory tract infection, COVID-19 exposure history, travel history, and appropriate isolation measures should be taken. And the number of personnel at the bedside to be minimized to only those required for direct patient care. Then procedure for airway management, everyone has already told, for potential COVID patient requiring emergent intubation should be followed, as they have already told about N95 mask, face shield, and the intubation apparatus with the video laryngoscope. So these normally we have to concentrate in the trauma emergency room. And what about the operation room? Everyone has clearly explained what all they have done in their hospitals. Now we have seen Debesh is telling about that operation room, and the doctor from PGM are telling about their operation room. But always prevent delays in critical operative intervention for unstable patients. Immediately they have to be operated. And already, as they were told, they have developed a hospital policy for managing patients in the operating room with known or suspected COVID-19. And ensure agreement are in place with anesthesia team for management of these patients. And what are you going to do in the intensive care? So here is a very important thing is maintain situational awareness of ICU capacity in the hospital. Most hospital, because the government hospital is overflowed, and so we have to know the capacity of the ICU hospital and ensure critical care needs for trauma patients have to be considered. And the most important thing, what we want to insist is the availability of life-saving equipments like ventilators, oxygen supply, and NIV, high flow oxygen systems should be monitored. So these are all the things what we normally should adopt in facing the emergency situations.
Dr. Ganapati, I think what you shared is excellent, but as you are a instructor, you are heading the CTLS, as the director of CTLS, I just want to know, because we are also having a lot of training centers, GVK, EMRI, we do a lot of training. Have you adopted any methodology where you can teach CTLS? For example, some of them have they started the training like a blender courses. One day they teach on webinar, and the second day they go to the place of their place and hands-on training they give. Are you planning any such type of training?
Yeah, definitely we are planning. So the main plan here, the main thing what we like to insist is how to protect and support the trauma team. So in that training, we have to train the team providers to undergo PPE fitting test and to review appropriate source of training in the use of PPE. And we want to promote individual behavior to prevent risk infection that we all know, like hand washing, avoid handshakes, covering the thing and all. And they should educate the community, regional and state disaster plan and resources. And another important thing what we want to insist is, as Dr. Anil told, that you have to educate the community, regional and state disaster plan resources and support social distancing and allow providers not on service and non-clinical staff to work from home. These are all things we just wanted to train. And mostly like this, we want to transition from in-person to virtual meetings for administrative and educational activities. And we want to restructure the trauma team and stagger cohorts to reduce the number of trauma or ICU provider in the hospital simultaneously to decrease exposure risk and preserve staff, and develop redundancy in backup schedules for provider who may be ill or exposed. And we also ensure that each team member has an individual plan to support child care and family needs. And we just want to insist that allow personnel with specific clinical skill to concentrate on their skills. For example, a surgical intensivist may need to help overwhelmed medical intensivist with the ventilator management of critical COVID-19 patients. And while general surgeons can assist in trauma alerts, emergency general surgery procedure, and floor rounds. And we should support schedule and team culture that optimize wellness and maintain resilience from the team members. These are all things we just want to adopt slowly and to have a one-day course.
Thank you, Dr. Ganapati. Dr. Chandrasekhar.
Thank you, Dr. Ganapati. Isn't it? Sorry, isn't it? In between something is net issues were there, isn't it? Kindly pardon me about that. It's a very good insight. Now I'll hand over to Dr. Raja.
Thank you, Dr. Chandrasekhar. I once again request all the panelists to be there because I'm seeing a lot of questions which every panelist may have to have some one or two questions. Now we come to the Dr. Shekhar Reddy, the last speaker of today in this panel discussion. He's a consultant, a facial-maxillary surgeon at Asian Institute of Gastroenterology, Hyderabad. He's also a teaching faculty in Panania Dental College, Hyderabad. And he also is a visiting professor to in UK, where he spends 6 months of his time there in UK since his daughter and all are studying there. And he also works there. So keeping this mind, all this experience in India and in UK, I think very recently he has moved to UK just 10 days back. So I just want him to enlighten how different he feels practicing here in India and in UK in this COVID era. Dr. Shekhar.
Hello, sir, and good evening, everyone. And it's a nice day here in Scotland, and it's the longest day here. The night will be only for about 1 or 2 hours. I came here about 5 days ago, and coming to this COVID, the aerosols probably is the biggest matter to maxillofacial specialty, along with anesthesiologists and ENT colleagues. So ever since this COVID thing has come up, I've been looking up information on these aerosols. Most of the information that we have on SARS-CoV is an extrapolated information or the best guess that we have from the information that was already available from other SARS type of viruses, but not necessarily from this particular virus. There is a recent study, which is very interesting. It is called COVID Track Study. The results of this study are available on the website ENT UK. They have looked at 400 tracheostomies that were done on COVID patients. And they followed up the clinicians for at least for 2 weeks, and they sent them a questionnaire to find out if any of these clinicians have developed any COVID. So these are the clinicians who has done tracheostomies on COVID patients in the intensive care units. Or some of these tracheostomies may have happened in the theater itself. Okay. So interestingly, no clinician has developed COVID symptoms or COVID infection from the tracheostomies that were performed. These are not a simple number. This is 400 tracheostomies. But all these tracheostomies were done by the people wearing full PPE. Okay. When we talk about full PPE, I was there in India until a few days ago, and I'm here too now. We talk about N95 mask. An N95 mask has to be fit tested. It is not like a ready-made shirt. It has to be individually tested against your facial structures. Unfortunately, we in India talk about N95 or N99 masks, and very hardly there is any fit testing done. An N95 mask that is not fit tested is useless. And please bear in mind, and it's much better to have 2 surgical masks, one on top of each other, if your N95 mask is not fit tested, because there is always air leak, especially around the nasal bridge. Now, coming to maxillofacial surgery proper, okay, what is the principles that we're following? And as somebody has said already, the incidence of facial trauma has increased secondary to interpersonal violence. And most of these injuries are either nasal bone fractures or zygomatic fractures. So you follow 3 principles, which is avoid, restrict, and abbreviate. What is avoid? Is this treatment is required for this patient? Is this zygoma fracture need to be treated? Or is this nasal bone fracture need to be treated? Can we wait? Can we wait until all the dust settles? And if this is not causing any functional problem, so as you know, maxillofacial injuries to look at, they look very ghastly. But once you clean the face, all the blood, etc., most of the times the injuries are not that ghastly. Very rarely you have issues of airway issues and bleeding. Those are different, but those are very rare. Okay, they probably are seen with high velocity injuries, but which are very minimal during the lockdown period, etc. So that's avoiding. bringing a patient to the hospital setting and making him spend a lot of times, etc., and posing a risk to everybody and to the community at large. Then restrict the aerosol generating procedures, or restrict the number of visits of the patient and restrict the number of staff who are attending to it. How do you restrict the aerosol generating procedures? I was trained in a government dental college to, then slowly I progressed to various hospitals of international repute, up to the Cambridge University Hospital where I worked last time as a registrar. So I've seen a lot of change in maxillofacial procedures, starting from wiring to the complex plating mechanisms. So I think we need to step back now, go back to the age-old techniques. Can we manage these facial injuries with simple procedures rather than undertaking complex surgical, time-taking procedures which involve a lot of plating and fixation, etc. So that's something that need to be, you need to think about. And for this, you may have to speak to the senior surgeons. And I'm not saying no disrespect to the junior surgeons, because some of the juniors may not even know that we were managing these facial injuries differently a few years ago. And no, Chandrasekhar sir probably knows. He has seen the progress of maxillofacial specialty more than anybody else, how it was being done once to how it's being done now. And now the other thing is, when it comes to treatment protocols, we have changed. We moved away from, we avoid now drilling. Okay, so the drilling is kept to the bare minimum that is possible. If at all it needs drilling, we use a slow speed drill and use the irrigation as sparingly as possible, wearing the full PPE. That's another thing. The next is, you develop treatment protocols that doesn't need a lot of follow-up periods, or the follow-ups can be done in such a manner that it can be done over a video consultation or a telephonic consultation. So I have a lot of details about specifics of maxillofacial surgery, how a particular procedure can be done, but I don't see many maxillofacial surgeons here, so I don't go into the details of it. But overall, we are trying to minimize the aerosol generation, like by adapting to procedures which are much more quicker, much more simpler, and taking a step back to see how we were managing these procedures when the drill systems and the saw systems or the reciprocating saws, etc., these were not available. By adopting those principles, so that the patient does not have to spend too much time in an operation theater. And then again, if a patient needs a lot of stripping inside his mouth, maybe we can minimize that surgery intraorally and do an extraoral surgery and fix that by sealing his lips and do the surgery mostly extraorally. So these are some of the procedures that we follow in the COVID era. I think I want to be brief, as no maxillofacial surgeons here, and I'll take any questions if they're there.
Dr. Shekhar, when the risk of exposure comes, at what level is a facial surgeon's place? For example, ENT surgeons are placed at level 1 or 2. So facial surgeons also come to the same level?
Yes, maxillofacial also at the same level. And in fact, maxillofacial surgeons use drill more often than any other surgical specialty. I mean, orthopedics also just, but we are there right inside the mouth. But there was, I'm carefully following a lot of studies that they are coming up now. If you can mitigate the risk by carefully following the proper PPE protocols. And this one study is a good example. It's not just simple figure, 400 tracheostomies on COVID patients. And all the clinicians have been followed up, and none of them have developed any COVID symptoms, which is a great study. And this is the results of this study are available on the ENT UK website, and there is very good information on the ENT UK website about the aerosols, etc. There are certain other things, like we don't want to use a monopolar cautery, or even if you are using a bipolar, use a very low setting. Some of these things, to stop the aerosol generations or the fumes, etc.
Thank you, Dr. Shekhar.
Dr. Shekhar, I really very great things you have exposed. Number one is previously we never used to use an N94 or N99. It was in the pharma industries they used to use it.
Yes, sir.
There, according to your contour, they used to manufacture, but because of the bulk, it is not possible. So it is not properly fitting to your contours. So there is always there is a leak in it.
Yes, sir.
So what we are doing it, first and foremost, you have to seal it with a plaster. Then
Yes.
over and above, you wear the 3-ply mask. That is a
Yes.
surgical mask. That prevents a lot of gives a little more protection. That is one thing. Second thing is, as you said, cautery should be very, very minimized and used in a bipolar rather than a monopolar.
Yes, sir.
And
Cut to a low setting. Yeah.
Prevent as far as possible the aerosol generation. And if you are wearing and if you are following the proper protocols, like wearing the PPE and doing in a systematic way, you can avoid. I totally agree with you, and that has shown. Almost 400 tracheostomies.
Yes, sir.
None of the doctors have been infected. So that is a great insight. Thank you very much.
What may be the reason for none of the doctors doing so many of tracheostomy? Were they fully protected by personal protection equipment?
There are two reasons, sir. One is they are using the PPE, that's one. And the risk from this aerosol may be over-exaggerated too. So there are only two options here. There are only two protocols. There are only two possibilities.
Okay. Thank you, Dr. Shekhar. There are a lot of questions. Some of the questions I want to ask, which are interesting for everyone. I think mostly it is for the trauma surgeon and the trauma anesthetist, Dr. Kajal and all. I think this question, how is sanitization of CT and MRI done for post-COVID-19 patients? Dr. Debashish or Dr. Kajal? Anyone? Debashish?
To be honest, I don't know. I don't know. This is not
Anybody here can answer, Dr. Bala?
We use sodium hypochlorite solution, 1% sodium hypochlorite solution. Using a same PPE, the housekeeping staff are trained, they're fully donned with PPE, and they just wipe the surfaces manually. And now that you have got the spray, you can use the spray machine, but manually also will not take too much of time.
I agree with Dr. Anil. Clean it within a 1% sodium hypo. Then even a walls also should be cleaned and floor also should be cleaned. Not only the equipment. Then after that, it is you have to fumigate. Wait for 20 minutes before taking for the next case.
So one issue with the sodium hypochlorite is it's a corrosive. So one of the things which has been suggested is to use 5% Lysol or Cresol. Alcohol-based solutions also are equally effective and they're non-corrosive. So probably that needs to be considered when we use it extensively.
Well, I agree with some people. They said even soap water is also equally enough because it's in a fat. Dissolving. What do you call this? It's in a soap water. It dissolves fat. Even a soap water is enough, and wait for 20 to 25 minutes. Then it is safe. But sodium hypo, even though it is a corrosive, these are all the metallic areas we can use in a sodium hypo. That is among all sodium hypo is the best solution proved.
But we have to be very careful, as Dr. Bala told. Actually, long back, 6-7 years back, we used sodium hypochlorite solution in higher concentration. Unknowingly, some of the ambulance people, they cleaned with higher concentration, and to our surprise, what we saw is most of the equipment which were there in advanced ambulances, like ventilators and all, they almost got damaged, like they were not working in a proper way. From that time, so we made it very clear that not more than 1% sodium hypochlorite solution. If the concentration is a little bit high, definitely it will damage most of the equipment also.
You're right.
Doctor, my next question is for Dr. Debashish again. Doctor, can you explain about CO2 insufflation and suction and little more about the position of the patient during a laparoscopic surgery in this COVID era?
Sure. First of all, the problem with laparoscopic surgery, again, as Dr. Shekhar Reddy in the UK had mentioned, I am not quite sure how big the aerosol risk actually is. But however, in light of the lack of proper evidence, we have to accept the fact that aerosols can infect. Now, the problem with aerosol generation during laparoscopic surgery is that although it is all happening within the peritoneal cavity, but as all of us who have done laparoscopy know, you can actually even smell that the air that leaks out at the port sites around the ports. So even if you use diathermy, you can smell the fumes because they leak out from the port sites. To reduce the amount of aerosol that is leaking out from the port sites, what we do is we use a completely separate suction device which is connected to one of the ports. So basically, you have a standard suction tubing which is connected to one of the ports, and this tube then goes into an intercostal chest drainage bag, which is primed with sodium hypochlorite solution. So in a sense, the suction device sucks out the aerosols from the port, runs it through the hypochlorite solution, and the exhaust from the ICD bag goes straight into the central suction. We put an inbuilt filter between the two, similar to the ones that the anesthetists use in the ventilation circuit. Now, this is to prevent the aerosol from leaking out into the general OT complex. The second thing that a lot of surgeons are doing at the moment is that they are reducing the flow rate of the carbon dioxide, reducing the insufflation pressure of the carbon dioxide. So like normally in general surgery, we would set the pressure at around 12. They will start off with the pressure at 8. A normal flow rate is about 20. They will start off with a flow rate which is around 10. And if they can complete the surgery, they will maintain it at that pressure and that flow rate. And obviously, if there are difficulties, you do it in the normal settings. So the main precaution is the suctioning of the aerosol that is being generated inside the abdominal cavity.
Thank you, Dr. Debashish.
Thank you, Dr. Debashish. One more question for Venkat. Dr. Venkat, it is in a post-operative, how do you manage? Even post-operatively also, they vomit, they cough, and a lot of aerosol generation is there. How do you manage post-operatively?
Dr. Bala.
Bala Venkat.
All these patients have to wear a mask actually. They're all wearing a surgical mask when you send them out if they are non-COVID. And if they are COVID patients, then they're supposed to wear N95 masks. So this is the way you can reduce the aerosol spread by coughing.
Yeah, I think I go with that, sir, because these are the recommendations that we need to do. And but one thing we need to keep in mind is COVID positive patients have got real poor outcomes because of the immunity. Yes. So I think until otherwise it's really needed, I think we shouldn't operate a COVID positive patient if could wait. And otherwise, I think I go with what Dr. Kajal said, the protocol to be used.
Oh, I agree, Dr. Venkat. These cases, especially the COVID positive cases, their lung compliance and their the status is completely compromised.
And immunity so, also, sir.
Immunity also.
Yeah.
Post-operatively, if you are keeping the N95, even a normal person is also breathing through the N95, it is a bit difficult. So there is a lot of issues when you are wearing when the patients are wearing the N95 mask. So yeah. How do you manage this?
No, actually, sir, if that is the case, potential cases, it's only the healthcare workers around have to be protected, because we don't have negative pressure rooms in India. There are very few hospitals possessing negative pressure rooms. So in this scenario, it has to depend upon the infrastructure. In this scenario, I think all the healthcare workers should be on full PPE. That's the only way forward.
Thank you.
One question is there for Dr.
Raja, it's up to you now.
Ramana Rao, or Dr. Chandrasekhar. One question is there for Dr. Ramana Rao. Is he there? Dr. Ramana? Okay. I think he's not there. One more question. I think I don't know whether Dr. Ganapati or Dr. Bala or Dr. Debashish, because it's related to ATLS, or Dr. Anil. Are there any updated, changed protocols for ATLS after this COVID, in this COVID era? Have they come out something on the website, any new guide, not CTLS, they're talking about ATLS.
Yeah, in the ATLS, in the first page, they have just given all the protocols and what has to be changed for COVID-19 patients.
Oh, okay.
First page in the ATLS. First page itself they have given.
Dr. Chandrasekhar, you want to have any other questions? There are questions, but I don't know whether it's too. Each one question is there for Dr. 2 or 3 questions are there for pre-hospital care. I think Ramana can answer it.
Dr. Debashish, you said it is generally you're going for the HRCT, and along with it is possible it's an RT-PCR. You're more dependent on the CT. The study was that specificity is about 80%, 88%, and the sensitivity is about almost 90%. Even some studies say that it's more than RT-PCR. Do you agree with this? CT is a mandate along with the RT-PCR?
Yeah, I think very pertinent question. Thank you for asking this. Even without comparing the sensitivity and the specificity, I think what our thought regarding doing our HRCT is not the sensitivity or specificity, this is better than that. No. Our reason for doing an HRCT chest is 2. One is that we are all worried about the period from the patient's contamination to the patient's first symptom, so-called incubation period of the virus. Now, during what we are trying to do is identify people in the incubation period. And as we know that RT-PCR usually is positive earliest around day 4, day 5. What we have found is that in the first, and I must add that this is entirely from the history that the patient gives, which may be completely inaccurate. What we have found, if the patient's history is accurate, HRCT chest will warn you even before RT-PCR comes back positive. So we are adding HRCT chest to RT-PCR just to increase the sensitivity of the whole diagnosis of the patient. That is one reason. Second reason is we have a problem in our hospital that we do not have facilities to do RT-PCR around the clock. So for patients coming into emergency, say anytime after 12 noon onwards, we can't do their RT-PCR before the next day. But we can do HRCT chest 24/7. And therefore, we are using that before the next day's RT-PCR to make these patients either clear or suspect or highly suspicious, because as we know, HRCT chest, American College of Guidelines has these 4 categories, and we can then classify them as highly suspect, inconclusive, low suspicion, clear. So this is why we are using HRCT chest. I think the debate is still on whether one should do it, one shouldn't do it, but we have devised our own protocol based on the information we have.
Madam, Kajal Madam, it's open for you now. Your comments.
Regarding HRCT, well, we are not doing HRCT because we are getting the RT-PCR done twice a day and gene expert at any time of the day. So we are relying on those tests rather than going on for HRCT as a routine Dr. has mentioned. But yes, HRCT
Your voice is not there, doctor.
Voice is not there.
Yeah, now it's there. Now it's there. Yeah.
Okay. So I said we are not doing HRCT routinely. We are doing Gene Expert and RT-PCR, as both these tests are available to us throughout the day. So we are relying more on these two tests. But yes, HRCT is advocated test nowadays. It is advocated. So we are not doing it.
Dr. Kajal, is most of the centers they don't have any gene testing. Most of the centers they have an RT-PCR, and the CT is more available freely. So these are the two areas people have to take an advantage. And
So I guess it may be a modality for them too.
Yes,
Because
and I agree with Dr. Dev. Yeah, I agree with Dr. Devshish. The CT changes are much earlier than the RT-PCR changes. So we can rely even the day 2 also CT changes we found, whereas in a RT-PCR it takes a little more time. So for that reason, is both put together, RT-PCR and CT chest, the accuracy it will become a little more. It is 96-97%.
Trauma
Voice is not clear, Dr. Kajal. Your voice is not
You are
clear.
disconnected.
Dr. Kajal. Dr. Jain. Okay. Before.
Okay.
Okay, actually, I wanted to ask Dr. Kajol or Dr. Balavenkat or Dr. Debashish. We had this experience. A patient was there for an emergency trauma patient, but the emergency was like a think that it is an ophthalmic emergency, trauma to the eye and all those things were there. When the patient was 65-year-old and they have taken an X-ray chest, and the X-ray chest clearly shows a consolidated lung, and there are, apart from that, he is asymptomatic. So the physicians, what they have written is to take that patient without further investigations as it an emergency. What is your, if you are in there, my position, were you able to, do you wanted to take that question, patient, Dr. Bala, Dr. Kajol, or Dr. Balavenkat? Dr. Kajol, did you hear my question?
Yes, can I hear the question again?
Yeah, a patient, a emergency patient, a vehicular accident, he had injury over the eye. They have done the CT and all, everything is normal, but when they did the chest X-ray, they didn't do the HRCT of the chest. They didn't do the CT of the chest, but they done the CT of. When they did the X-ray chest is having consolidation, and the radiologist himself he has written that the consolidation may be due to some infection, but the patient has been posted for surgery without any further investigation. Do you accept that patient, Dr.?
No, we don't. We are doing universal testing for all trauma patients. And if there is any evidence of infection, a patient has to undergo, otherwise have time, say this is the same patient or extradural hematoma evacuation. Then the PP precautions have to be taken, full FFP3 precautions, and they have to be treated like COVID positive patient. The entire team remains inside the theater till the test report comes. You have to take them as COVID positive patients.
Thank you. Thank you.
Always a pneumonic consolidation is always suspicious for the COVID.
Yes.
So you take all the precautions and do it as is in a positive case.
Yes.
Am I right, Dr. Kajal, madam?
Correct. Absolutely correct.
But I think if there is any threat to the organ, like there is eyesight being lost, etc., then the patient will be taken as COVID positive with all the precautions. But if it's only a bone injury or a soft tissue injury, which can be waited until the test results of COVID comes, the case can be postponed.
No, but still they have the time. They can take HRCT at least. I think even if
Yes. I mean, you only rush to theater if there is a threat to the life or to the organ.
yeah. Thank you everyone for this.
If I may just add one more thing, I fully agree with whatever Dr. Jain, Dr. Shekhar, and Dr. Shekhar Scotland said. The only question
Not
is,
not more than 5 minutes.
if they have already done a CT of the head, why couldn't an HRCT chest be done in the same city?
They didn't thought anything about the chest. They were worried about everything and the upper
Head
part.
injury, yeah.
That is
So when
something
they
that
came to the hospital for investigation, as we are routinely doing for all patient X-ray chest, we have written for X-ray chest. So they did the X-ray chest, but CT is not there in the hospital, so they have to go to some other place to do the CT. That's the reason why they are hesitating and they want to post
That's
the
the problem. Yeah.
Any other questions? They have some questions for Dr. Ramana. Dr. Ramana Rao, sir. He's not there. Dr. Ramana is not there, I think. Any other questions?
Dr. Raja?
Yeah.
All the elective cases, I'm sure it is in most of the hospitals, they have started the elective cases.
Yeah.
These elective cases, always we have to screen, and unless until it is a negative, it's better not to take a cases directly. Right from the gate onwards, say it's in a thermal scanning, and you run a fever clinics. In the fever clinics, you have to examine the patient, then go to the HRCT, etc. So that is a safer way of doing it.
Okay. Actually, I wanted to ask Anil, Dr. Anil is there. Anil Mulpuri was telling that the investigations still are not going on. I think in Telangana very recently they have a statement that all the private institutes can also go for all the tests. Am I correct? Dr. Chandrasekhar, you should answer this.
Yeah, some of the private institutes still they are crossing their fingers because of the rates what they have announced in Telangana. They are not happy. They are negotiating with the government. And second thing is, some of the institutes they are doing with the 2,200 rupees. Most of the institutes they are not doing.
Was telling that the investigations still are not going on. I think.
Hello.
Hello.
Yeah. Most of the institutes still they are not doing it. I'm sure it is in a couple of days it will be. I mean, discussing with the government. In a couple of days it will be solved.
With regard to the elective cases, can I just tell you about the policy that being followed here in maxillofacial surgery? In elective case, the patient is advised to be in isolation or home quarantine for 14 days before he come to the hospital for elective surgery. And before he is posted for surgery, the RT-PCR done twice before the case is taken up. It may be a bit too much over the top, but the patients are advised to stay in isolation for 14 days before they come up or taken up for surgery.
Shekhar, it is in RT-PCR is also it is always in crossing fingers. Even
Yes.
for the Delhi, the health minister first proved to be the negative, then the second time it is proved to be positive.
Yes,
there
sir.
are a lot of cases are there. First they are negative, and after
Yes,
sometimes they are proved to be positive. So
yes, sir.
Everything is clinically, and see the investigations. You have to use your common sense in many areas. So there is no hard and fast rule for each and every patient. There is no decided protocols are there. Every patient differs with another patient, and you have to use your common sense. to protect yourself and the other healthcare professionals.
Yes, sir, I agree.
Coach Dr. Ramana is there. Dr. Ramana, what precautions are being taken by the ambulance worker with or without patient in the ambulance? Dr. Ramana is again gone.
I think he's not there.
Okay. The other question, I think Ramana, if is not there, I can answer. The other question is, when there is an announcement of code blue in the hospital, what are the minimum personal protection equipment they have to wear? Because it's a emergency. I think Madam, the one who asked is, I think she's a gynecologist. So the minimum protection, what they are taking is a face mask. What we are doing is face shield, a cap, and the shoe covers, and 2 pairs of gloves. These are the minimum protection what we are telling to do when they are doing the CPR. And while doing CPR also, we are advising them to put a plastic cover, plain plastic transparent cover over the patient and then do chest compressions. That is the thing what we are following. And it takes hardly 10 seconds for them to wear this minimum, this PPE equipment, the face mask, the face shield, the cap, the gloves, and the shoe covers. If you want to wear the gown, it's well and good, but it takes 30 more seconds to wear the gown, surgical gown and all. So these are the things in our hospitals we have maintained in all floors. On all the crash carts, we have put the transparent sheets so that whenever they want to do a CPR, they can cover the patient and then do the chest compression. I think I answered the question what has been answered. I don't know who has answered the question.
I totally agree with Dr. Raja. Now it is instead of the code blue, we are adding the COVID code blue.
Yeah.
COVID code blue.
Yeah, we are adding.
Some people are using as a code orange.
RH, and I think in Ganga Hospital and all, they're adding code blue orange. Am I correct, Dr. Bala? In some of the hospitals, they're code blue orange. How about you, Dr. Kajal? Anything specific name?
No, I agree with whatever you have said. Only thing we have to remember in pandemic is that there is no emergency. At least some minimum safety measures should be followed.
So according to me, the minimum safety is face mask, face shield,
face mask,
gloves, and the shoe covers if they can wear. That is the minimum. Dr. Ramana, is he there? Again, the question is repeatedly. Okay, then he's not there. I think they are sterilizing the ambulances in a proper way. Any other thing want to? Kevin, can we? Dr. Chandrasekhar, can you?
He told very clearly they're cleaning with a 1% sodium hypo. Then with an aerosol, they have guns are there. They are cleaning with it.
Okay, okay then. So that is
aerosols. We discussed quite thoroughly because dentistry in dental offices, this has been a big thing. We have been jobless for the last 3 months, and the dentists are desperate. And we discussed this quite thoroughly. And the points that we make sure are: one is there is a good exhaust system. There is a direction of airflow from one end of your office to the other end of the office. The air is being fed from the front door, and you have an exhaust from the other end of the office. The third thing is most of the dentists are using hypochlorous, or they're not using hypochlorite because it's destroying a lot of dental equipment. Either hypochlorous or hydrogen peroxide with silver ion as fumigation. Not fumigation, what's the word? Fogging. It's like a fogging, not fumigation. And basilol as for surface cleaner. And then they're also using an air purifier with a minimum air exchange rate of at least 16. So these are the measures that dentists being using. And touch wood, in the literature, so far there are no dentally clustered COVID patients who can be related to a particular dental practice. But as dentists started practicing, I think in the United States, they went back to practice about 2 weeks ago in some states. And so far, some practices have continued even well into the COVID. And touch wood, there has been no cases of COVID transmission, which can be clustered to a particular dental office, has been reported. So there may be something, as I said, maybe there may be an over-exaggerated reactions towards this aerosol. I'm not saying that we should not take precautions, but if you you probably can mitigate the risk if you follow these precautions. And that is evident from this study, which is published on the ENT UK website.
Dr. Shekhar Reddy, since you have said this, one of the questions is for you. Are these facial injuries due to increase in domestic violence during the lockdown?
It has been seen, the fist injuries. I'm not sure about UK, at least in the Western countries, people are in the house and, the discussions, altercations are exaggerated, and increased facial injuries from interpersonal violence are seen.
So if I may add, we have seen these facial-maxillary injuries with alcohol use. Patient are falling down from the staircase, landing up with head injury and facial-maxillary injuries. We have seen more of machine cuts in our center.
Yes. That's there, but alcohol has been mostly restricted in where I was in Telangana and Andhra for so long, and they released it afterwards. They cannot sustain the government for so long anyway.
Even now, some of the people they have went into the psychological trauma and they're behaving a little odd also.
Yes. On one example, I shaved my hair completely. Got bored. tired of having showered too many times and just shaved everything.
That is one of the format basically.
Yes, sir. Yes, I think I feel more confident now because once the hair is shaved.
Nice.
So, I think
Dr. Raja.
I think we'll ask Tanmay Das to close this. Dr. Tanmay Das ji.
Are you there, Dr. Tanmay?
Yeah, thank you. Yeah, I'm there. Actually, I was wondering if all of us could come up with a way of a new method of teaching trauma. Trauma teaching has to be modified in these times. While we can use the webinar for sharing slides, it is the hands-on teaching which needs a little bit of thought. How we can continue with uses like ATLS and CTLS, the hands-on part. That is what I was. There are a lot of trauma teachers here. Maybe we can designate one person in each hospital who is already trained for the hands-on teaching, and it will be quite some time before we can get together again and do a hands-on session. We can use mannequins, we can use designated persons. This is what we want to involve with.
You are right. It is a long time we have never met. It is in a high time we have to meet and we have to evaluate certain protocols for the training purpose, especially for the youngsters. This is a high time and this is the right time also to train.
So it was, other than that, I think it was a wonderful get together and a lot of sharing about what all we are doing. And all I can say that a solution to this pandemic should come around as soon as possible, whatever it is, whether a drug or a vaccine or some kind of immunity. So with that note, I would thank everybody and hand the mic back to Dr. Raja.
Thank you, Dr. Tanmay Das. Because Dr. Tanmay Das has told about that, I just, nobody asked this question. All our doctors, are they taking the prophylactic hydroxychloroquine? Because they're, just for my interest, I'm asking.
No, I'm not taking.
No.
Even I'm not taking it.
I would have taken it, but I stopped it after President Trump started taking it.
I have finished a course of chloroquine.
But the evidence is not yet
proved actually.
The evidence has been proved that it is not working. The UK recovery study, the first thing that they come out with is HCQ is useless. And then later on they added this dexamethasone, which is useful.
A lot of an advantage are that dexamethasone especially people are going towards the steroids basically.
To be seen.
So, Dr. Chandrasekhar, can you conclude the session?
I'm very glad Dr. Raja, he has arranged a wonderful session, and all the panelists are really very good, and they have given a lot of insight. And I'm sure it is all the people who have listened this, they have a take-home message. I'm sure it is we have to take care of everybody. Kindly take care of yourself. Every this sort of situations, they'll end up, and there is a sunshine will be there. I'm sure it is a day will come, maybe in 3 months, 4 months, or 5 months, or 6 months, and I'm sure it is definitely we'll see in the sunshine. Take care till that period. All the best. Thank you very much.
Thank you, Dr. Chandrasekhar. I thank all the panelists, Dr. Kajol, Dr. Debashish, my moderator, Dr. Chandrasekhar, President Dr. Tanmay Das, Dr. Shekhar Reddy, Dr. Ganapati, and Dr. Bala Venkat. I don't know whether still there or he has left. Dr. Matthew Sterlo, and each and everyone.
Your colleague, Dr. Ramana Rao.
And Dr. Ramana Rao, my good old friend, Dr. Ramana Rao. So I thank each and everyone to be here who has participated in this webinar. And I thank Dr. Chandrasekhar. He has motivated me when I told, shall we conduct? The first word he told is, we'll conduct, because on behalf of ITC also, we were not conducting many of the programs from last conferences also. Whenever we wanted to conduct a conference on ITC, there were some hurdles which were going on, and in this region,
Dr. Raja,
we wanted to conduct. Yeah, tell me, Doctor. Yes, tell me.
Actually, we are doing annual trauma critical care meeting in PGI Chandigarh, and when the sessions open up, when we are able to hold the meetings, we will definitely host one. We are doing every year for the last 3-4 years. We do annually one meeting.
Okay.
Which is solely based on trauma.
Thank you, Doctor.
So nice of you. So nice of you.
So nice of you. Thank you very much. So I thank one and all the participants who have taken action.
Thank you. Bye-bye. Bye. Thank you.
Thank you very much.
Thank you very much.
Thank you very much.
Thank you, Raja.
Thank you, Doctor.
Thank you.